Good morning, everyone. Dr. Sad Bonham is actually not able to attend because he got wrapped up in jury duty, so he won't be here. So I'm going to introduce Dr. Latremoulaire, and he is going to be presenting on interactions between sleep and pain. He graduated from UPMC in Paris with a PhD, completed neuroscience postdoctoral program at Mass General Hospital and Boston Children's. He is assistant professor in neurosurgery, neuroscience department at Johns Hopkins Hospital. And his research, he specializes in the neurobiology of sensory systems with an emphasis on pain and its module. And it's research in, I would think, like the early stages of this, and there's no disclosures. So I will turn the program over and we can start.
Well, thank you very much, and good morning, everyone. It's a great pleasure great honor for the invitation and a great pleasure to present some of the work we've been doing. So I will be turning off my video so it's less distracting and move on to the slideshow. And so my name is, as you said, Alban Latremoulaire, and my lab is studying has a great focus on the interaction between sleep and pain. And so today I will describe two big projects we've been running trying to answer these questions. So I would start by saying that the overall interaction between sleep and pain is pretty well recognized, has been more and more recognized in the last 10 years or so. And in a simplified version of it, people will describe it as a vicious cycle where pain is going to prevent sleep, and sleep being disturbed will worsen pain, and then you have this ongoing cycle where everything gets worse. And there is indeed data to support this view of this interaction. In the clinical settings, over 50% of patients that have chronic pain will complain about sleep problems. And these sleep problems could be difficulties to fall asleep, waking up at night, and the overall complaint that they have non-restorative sleep and daytime sleepiness that is impacting their quality of life. And on the other side of the equation, there's been a lot of data, experimental data, both in humans and in animals, showing that when you disturb sleep, you are increasing pain responses. And you can see that many studies have found it. It's very consistent, actually. It's quite strikingly consistent, no matter which species you're looking at. And when you alter sleep, you have an effect on pain sensitivity. However, the precise mechanisms of these interactions are unknown at the moment, and they appear to be much more complex than what we might have initially expected. And so today, I will show, as I said, two projects showing the two sides of this equation. I will start with one looking at how sleep is affected in patients with neuropathic pain. So neuropathic pain, as you all know, is pain that can occur after an injury to the nervous system. And the main symptoms associated with neuropathic pain are sensitive, sensory in nature. And so that's a mixture of a loss of sensation and numbness, coupled with abnormal pain sensations such as hyperalgesia, when you have more pain for a noxious stimulus, allodynia, when something that is non-painful is now felt as painful. And typically, patient will describe that a light touch is felt like a cigarette burn or scalpel blade. So it's very intense, very traumatic. But perhaps the most problematic symptom, pain symptoms patients with neuropathic pain have is spontaneous pain. It's pain that can occur without any external stimuli. It comes almost at random and usually very intense, and as you can imagine, extremely debilitating for patients. In terms of research, the first three symptoms can be assessed to some extent with various sensory tools, again, both in humans and in animals. In humans, it's quantitative sensory testing, and in animals, well, pretty much the same tools with some variations. However, for spontaneous pain at the moment, this is a symptom that is not easily quantifiable in patients, and it's not really quantifiable at all in rodents. But neuropathic pain patients also suffer from a lot of non-directly sensory symptoms that affect their quality of life. And if you look at the top complaint that patients have besides the pain itself, You see that here highlighted in yellow are the response from a questionnaire in specifically neuropathic pain patient. And you can see that the 3 top complaints are related to their sleep or feeling tired and not having restorative sleep. So this is highlighting how much sleep problems are a major issue for patients with neuropathic pain. However, while this problem has been confirmed in many clinical settings, I think everyone nowadays know that the patients have poor sleep quality, but the nature of the sleep problems are not known, because questionnaires are great at identifying there is a problem, not so great at determining the nature of the problem. And to do that, you would need to do polysomnographic studies to do quantitative analysis of sleep. And unfortunately, for many reasons, there have been no polysomnographic studies with patients with traumatic nerve injury. This is not an easy population to study, and it's especially hard to try to follow them over time. So at the clinical setting, there is no polysomnographic studies in patients. So polysomnographic studies, which would allow to record specifically brain waves, to study types of sleep stages, amount, architecture of sleep. And so that is what we are doing in the lab in mice. So we're doing electroencephalogram, electromyogram recordings, and the main mouse line we're using is C57 Black 6J to have common genetic background. So typically the surgery involves placing 4 electrodes at the surface of the brain and 2 electrodes in the neck extensor muscle. And through these electrodes, you can get the EEG and the EMG signal that allows to distinguish 3 states in rodents. There's wakefulness, non-REM sleep with the big waves, and that's where the deep sleep occurs, and REM sleep, that stands for rapid eye movement sleep. But you can also detect it through the muscle atonia that is prominent in this stage, where basically the animals, it looks as if they're awake if you look at the EEG, but the EMG is flat because of the atonia. So that is how we can do objective sleep measurements in animals. The advantage of that is we can actually have very good baseline animals before injury to get a good sense of their sleep. And then what we did is subject those mice to peripheral nerve injury. And the first model we used is called the spared nerve injury, SNI, where you cut and ligate 2 branches of the common sciatic nerve and you leave 1 intact, the sural nerve. And this model of nerve injury is widely used and has been associated with strong signs of evoked pain hypersensitivity. So you can see here, they developed mechanical allodynia. In gray is a sham animal at the threshold at which they will withdraw their hindpaw. And in red, you can see mice that had the spared nerve injury when there's a drop in the threshold. So now a very, very light stimulus is enough to trigger a very strong pain response. You can also look at dynamic allodynia, similar principle, but it's just like the stimulus moves. It's a pain brush that we're using. And you can also assess cold allodynia, where the animals are exposed to a drop of acetone that is cooling the skin. And while normal mice don't really focus on that, they do a little flinch, mice after nerve injury show strong signs of pain hypersensitivity here. So that was the initial setup, looking at the baseline of their sleep, then performing peripheral nerve injury and following those mice over time to see the quality of their sleep and the nature of the sleep problems. And the first observation we had was looking at the whole amount of sleep and wake after nerve injury. And the first result was, let's say, a little bit disappointing, but not unexpected, is we found no difference in the total amount of wake, non-REM or REM sleep. So in black, you see the mouse before injury, and in red, different time points after peripheral nerve injury. And so the first result was that if you look at the whole amount of sleep, well, mice were sleeping the same amount after nerve injury than before. And that was true also if you look at the distribution of sleep-wake during the day. So the circadian distribution of sleep and wake, which is reversed in mice, was maintained after nerve injury. The animals were sleeping more during the light period, and they were more active during the dark period. However, when we looked at the sleep architecture, that's where we found a stronger phenotype, or phenotype at all, is that we looked at the number of non-REM sleep episodes and their overall duration. And what we found is that there was an increased number of non-REM sleep episodes coupled with a decrease in their average duration. And because the total amount of sleep is not changed, what it indicates is that there's a fragmentation of non-REM sleep by peripheral nerve injury. This non-REM sleep fragmentation was very consistent over time. So I show here up to 7 weeks after nerve injury. We actually had some mice that we kept for over 6 months. And once they developed this fragmentation, they kept it in this model. And also it's pretty stable. We here show a heat map of 8 mice as controlled, controlled by themselves. So in green is the baseline with a normal sleep, and they all develop similar amount of extent of non-REM sleep fragmentation after nerve injury. So the results of this non-REM sleep fragmentation after nerve injury is that mice were far less likely to be able to do long bouts of non-REM sleep. So the finding episodes of non-REM sleep that were lasting over, it's 10 minutes was very rare, and instead they were spending a lot of time doing shorter bouts of non-REM sleep. However, if you look at the spectral profile of their non-REM sleep when it's not fragmented, we found that there was no difference overall before and after injury. That would indicate that sleep homeostasis itself doesn't seem to be impacted by the nerve injury. It's just like the sleep can be done, can occur when it needs to occur, but it's fragmented, it's shorter. We also looked at REM sleep, another type of sleep, and found that in contrast to non-REM sleep, this was not affected by nerve injury. So the amount were not changed, and the architecture was absolutely not impacted by nerve injury. And similarly, the spectral profile of REM sleep seemed intact, indicating that nerve injury did not impact REM sleep and had a very specific effect on non-REM sleep in mice. So then we wondered, what is the nature of the wake episode that fragment non-REM sleep in those animals? So to analyze this, we looked at the episode of wake that occurred during non-REM sleep, the one that fragment non-REM sleep, and we looked at them by their duration. And in this graph, what you can see is that the change only occurred for a very brief wake episode. So mice did not develop signs of what could be some type of insomnia. That's not like they stay longer awake before they can go to sleep. That would have been seen here, but rather they see an increase, significant increase in number of what we call brief arousals. Just not full wakefulness yet. Those are lasting less than 16 seconds. So chances are mice or humans are not even conscious about those events. We do have some spontaneously during the night ourselves, but here we found that after nerve injury, this number was strongly increased. So what we did then is go back to the EMG traces of our mice and monitor all those brief arousals we could spot. You can see here on this trace, 3 of them. Brief arousals to be quantified need to have a concomitant activation of the EEG, means instead of those big waves, it flattens, it gets activated. And then coupled with that, you need to have an EMG activation to confirm that the animal starts moving. And so that's the duration of the activation, the muscle activation, that defines the duration of the brief arousal. And you can see here that we found 3 of them, and we manually tagged them to get a better sense of their distribution before and after nerve injury. So here is an example side by side of one animal at baseline and then after nerve injury. And this pretty busy slide, you can see the spectral profile, the EEG. Here it's a way of derivative of the EMG. And when you see a peak that you have, that means you have motor activity. And at the bottom, you can see a hypnogram. And on this hypnogram, all the red dots correspond to brief arousals. So what you can see here is that some brief arousals are going to be quantified as wake if they last long enough, so typically 10 seconds or so. But the ones that were occurring more after nerve injury tend to be even smaller and therefore are not even counted as a sleep interruption with the traditional scoring system. So they're highlighted here, all those dots. And so when we quantified the duration of the actual duration of the brief arousals occurring after nerve injury, we found that on top of being brief, only the ones that were less than 8 seconds were significantly increased after nerve injury. So all of that to show that looking carefully at what happens after nerve injury in sleep architecture, the main difference is an increase of brief arousals lasting less than 8 seconds. So we then wanted to look at other chronic pain models. And first, we looked at a model of transient neuropathic pain. So in this case, we crushed the sciatic nerve, and that allows the fibers to grow back and reinnervate the skin. What's interesting with this model is that when you crush the nerve and the fibers regenerate, there's a transient phase of pain hypersensitivity highlighted here in red. So when the fibers are reinnervating the skin, mice are hypersensitive for a few weeks, but by 5 weeks, most of the animals return to normal sensitivity. Mice are actually pretty resilient with that. So we looked at their sleep fragmentation during this time period by looking at the number of brief arousals and the duration of non-REM sleep episodes after sciatic nerve crush. And we found that when the mice had abnormal pain sensitivity, and I would say an active nerve injury, they had sleep fragmentation. But interestingly, when the nerve injury ended, so to speaking, when the nerve reinnervated the target tissues and the pain sensitivity was back to normal, then sleep was back to normal as well. So there was associated with the nerve injury and associated pain symptoms. So then we extended to other pain models with different etiologies to find if all type of chronic pain are associated with these symptoms or not. So to do that, we use various common chronic pain models. The first one was complete Freud's adjuvant. So it's basically a mixture of dead bacteria that you inject intraplantarily, and that causes a massive inflammation in mice that's going to last several weeks. These mice develop a lot of evoked pain hypersensitivity, but their sleep was absolutely not fragmented after injection of these compounds. So while the mice developed pain, the inflammatory pain, their sleep was not fragmented. We also looked at a model of neurogenic pain by injecting capsaicin, which activates TRPV1 channels. And TRPV1 channel is going to activate specific nociceptors and cause a neurogenic inflammation. This is also associated with signs of evoked pain hypersensitivity. And again, we found that this was not associated with an increase in sleep fragmentation. And finally, we looked at a model of postoperative pain where you open the skin and move the muscle around, but without causing any frank nerve injury. And this is a very good model to study the short-term pain occurring after several surgeries. And these animals, again, did not develop non-REM sleep fragmentation. So basically, altogether, this data shows that the effects of the sleep fragmentation by brief arousals is specific to model of peripheral neuropathic pain by nerve trauma. So you do need to have a nerve injury to see the specific effect on sleep. So then we tried to determine the nature of the neural signal that is causing those brief arousals. So trying to understand where that happens. And to do that, we used a genetic strategy. So we used animals where we can silence specifically some cells. And the line we used were animals that would express the tetanus toxin specifically in neurons that express the NaV1.8 sodium channel. So the NaV1.8 sodium channel is only expressed in peripheral sensory neurons of small and medium diameter. So the animals we produce with this crossing are actually silenced for all the A delta and C fibers. So these neurons here are expressing tetanus toxin, and so they would not be able to release neurotransmitter. They are not killed, but they are silenced. We first tested in vitro that the construct was working by measuring the release of CGRP in the supernatant of sensory neurons stimulated and found that indeed the release of neurotransmitter was virtually abolished. And as a consequence, those animals are virtually insensitive to pain. Here I showed 2 examples where we use a calibrated forceps on the tail or heat source. And in both cases, those mice are not responsive to this. So they're actually very interesting animals, not that easy to take care of because they can injure themselves and show that pain, normal pain, is important for survival. But in this case, they were great. They did not, we confirmed that the sensory neurons were blocked. So what we did is perform nerve injury on these mice and tested the effect on their sleep architecture. And whereas the littermates developed the sleep fragmentation I just described with an increase of those brief results, those animals silenced for A-delta and C fibers did not develop sleep fragmentation. And as a result, their sleep continuity was maintained. So these data tell us that A-delta and or C fibers are driving sleep fragmentation after nerve injury. So the next step was trying to find out, and is still trying to find out, where in the sensory neurons this activation occurs. So here I show an example. You have the diagram of the mouse after nerve injury, and you see the sleep fragmentation that happens with an increased number of brief results and a reduction of non-REM sleep. What we tried to do in this experiment is block all the nerve terminals so that we used a cocktail of anesthetics with lidocaine coupled with the charged form of lidocaine, QX314. This cocktail blocks sensory fibers for up to 8 hours. So it's a very strong sensory blockade. And the idea was to indeed prevent any possible activation from the environment of these neurons after nerve injury. And then when we looked at their sleep, we found that actually it was not altering sleep fragmentation. It is still fragmented even when you block peripheral input, which indicates that the nature of the activity that occurs in these neurons is spontaneous in nature. But those neurons that we found where the A-delta or C fibers are spontaneously activated after nerve injury. Possible hypothesis for this would be the neuroma, the site of injury, where the ectopic activity could be generated, or the DRG neurons themselves, where recent studies have shown that you have sympathetic sprouting that can activate the soma of those sensory neurons. And we're investigating this. But the bottom line is we found that the sleep fragmentation is caused by a spontaneous activation of those injured sensory neurons. Next, we try to determine if this activation of sensory neurons was causing an activation of pain pathways. So we focused on one brain nucleus, which is called the parabrachial, and for 2 main reasons. First is that it's a major projection site for spinal nociceptive neurons in the brain. Basically, pretty much all pain neurons in the spinal cord, in the superficial horn of the spinal cord, are going to project to the parabrachial, but also because recent studies have shown that the subpopulation of parabrachial neurons expressing the peptide CGRP are strongly activated in the pain sensation, specifically the jumping and escape behavior when you're exposed to pain, but also that they could trigger an awakening of animals when there's a dangerous environment. In this case was too much CO2 in the chamber. So we reasoned that these neurons could also be the ones involved in causing brief arousals when sensory neurons are activated. To test this, we used, again, a genetic strategy with mice that express the Cre recombinase under the CGRP promoter, so that only these neurons I mentioned are expressing the enzyme. And we micro-injected AAV Flex DTA so that only neurons expressing the Cre would express the DTA, the diphtheria toxin, that will ablate them, or perform bilateral injection of the in the parabrachial nucleus. So when you use this, you can see the littermates have a nice presence of CGRP positive neurons in the parabrachial, in the lateral parabrachial nucleus. and that if you take animals that were injected with a virus, there's a pretty drastic loss of those CGRP positive neurons. And so once we had that, we measured their sleep fragmentation and confirmed that, again, these animals were protected against nerve injury-induced sleep fragmentation, indicating that the neural activity that is fragmenting sleep is activating a pain nucleus, and that therefore we believe the nature of the stimulus causing the sleep fragmentation is painful in nature. We also looked at the temporal resolution of these events that are causing sleep fragmentation. So we know that those are brief arousals, but we wanted to just try to measure precisely what type of stimulus or activation, I should say, what type of activation of sensory neurons you need to get those brief arousals. So to do that, we use another genetic tool, which is the mice that can express optogenic channel rhodopsin, which is a channel that you can stimulate with a blue laser, and you can trigger an activation just at the millisecond level. And this protocol we developed during my postdoc by Liam Brown is a very elegant model where you can stimulate the animals transdermally. So you place the animal and you shine a little bit of laser below on the skin, and the nerve terminals in the skin are going to be activated. And this is so sensitive that basically this technique, when you do a 10 milliseconds pulse of light, is enough to only trigger a single action potential in sensory neurons. So it's pretty much the best sensory resolution you can imagine. You can precisely trigger a single action potential in those animals and measure the consequences. And so what we did is use this strategy in mice that express channel rhodopsin in the Nav1.8 positive sensory neurons, the one I mentioned earlier, that includes all nociceptors. And when the mice were sleeping, there's big waves, we triggered the 10 millisecond light pulse, and then we recorded the awakening associated with it. You can see here an awakening, flattening of the EEG, and a muscle activity here. And one thing that was quite impressive is, well, two things were quite impressive, frankly, is first, the latency to awaken, that is less than 100 milliseconds. So that is very fast. But the second one, which was a little bit more surprising, is that despite the strong response associated with optogenetic stimulation, the mice, the vast majority of the awakening that these mice had were lasting less than 20 seconds. So an acute pain response, even very strong, is causing just a brief arousal. The animal will go back to sleep shortly after, within 30 seconds. And so we actually extended this and are working on doing that at the moment, where we're trying to play with this, the stimulation to get a good sense of what's needed to keep you awake or not. So here I show that's the EEG trace. When you have big bars going up here and at the bottom as well, that means the animal is sleeping. And then when you do a stimulation, you see that the animal wakes up. And so what we did is we kept stimulating every 15 seconds. So every 15 seconds, you have one pulse of 10 milliseconds stimulation. And when you do that, you can keep the mice awake. As long as you stimulate, they will not go to sleep. But interestingly, as soon as you stop stimulating in these animals, they will go back to sleep. And I think this, I actually like very much this result, that even though they are, in a way, they are obvious, but they're also a very nice way to confirm that if you want to keep an animal awake because of the pain, presumably a human, you need to have an ongoing pain stimulation. And that as soon as the pain goes away, the animals are capable of going back to sleep. And I think that can be extremely informative in the future for different pain conditions. But in our case here, I think it can help us tease out a little bit the type of pain problem those mice have after nerve injury. So here I show again the example of the profile, the nature, very brief arousals after nerve injury. And we found that through our experiments, the animals are, what's causing this fragmentation are spontaneous activation of nociceptors. So it's spontaneous pain. There are two main types of spontaneous pain, paroxysmal pain that is very short and very intense, and superficial or ongoing pain. That is typically a burning sensation that keeps going for hours, and sometimes almost forever, actually. So presumably, paroxysmal pain could correspond to an acute stimulation, and the ongoing pain is an ongoing repeated stimulation. And so looking at these results and the profile of our mice after nerve injury, we would argue that potentially what we found is that it's not just nerve injury that is causing sleep fragmentation, but it paroxysmal pain attacks that are fragmenting sleep in these animals after nerve injury. And there is some literature, some clinical literature that supports that. If you look at this beautiful study by Nadine et al., we looked at incidence of various pain symptoms in different etiologies of neuropathic pain. She found that basically paroxysmal pain was extremely present when you have a severe nerve injury, like amputation, plexus avulsion. But if you had other neuropathic pain conditions that didn't have a frank nerve injury, you were less likely to get these paroxysmal pain attacks. So we think that all mice, by definition, these are models of frank nerve injury, it's a whole sciatic nerve. So we think that this fits well, and we believe that that could be the same symptom that patients have. Also, it would definitely fit with the sleep complaints that neuropathic pain patients report, which typically is not that they cannot go to sleep, is that they don't feel restored. Their sleep is not restorative. That's the main thing they say. They're always tired during the day. And that is exactly something that you can trigger by sleep fragmentation. If you have sleep fragmentation, even though you don't realize because you're not awake during the night, you're not conscious about it, but you will have this sleepiness the next day. Okay, so we think now that using this potential biomarker or proxy measuring the peripheral results after a nerve injury could be used to detect analgesic efficacy of treatments. And I'm going to show you two treatments. We tried gabapentin, which is the first-line medication for neuropathic pain. And we tested these various doses and found that there is indeed a dose response improvement of sleep quality. We basically can restore normal rate of brief arousals and pretty much normal sleep duration with 10 milligram per kilo gabapentin, which is a pretty low dose in mice. Actually, it's a dose that is not enough to improve evoked pain sensitivity. So it's another argument suggesting that these brief arousals are not caused by evoked pain sensitivity. It's really the spontaneous pain that is causing it. And you can improve it with a fairly low dose of gabapentin. The dose at 30 milligram per kilo, which again is not a dose that is causing a sedation in mice. When you look at total sleep amounts or their latency to go to sleep, we think might already be a dose that is a little bit too strong, because you can see here the first 2 hours after administration of gabapentin, 30 milligram per kilo, the rate of brief arousals get below baseline. And that we think could be suggestive of a side effect that is commonly reported with gabapentin by many patients, that that makes their head go in a fog, they say. And it's a very bad side effect. So we think that here we might start seeing this, which actually means that we believe looking at EEG, EMG as a readout for pain can also help us get a sense of the potential side effects, CNS side effects of some drugs. We also tested carbamazepine, which is, I recently learned that it's supposed to be pronounced carbamazepine. Anyway, we use this compound that is widely used to treat paroxysmal pain attacks in neuralgia, trigeminal neuralgia, and found that again, at the dose of 5 milligram per kilo, that in mice is not sufficient to improve evoked pain sensitivity, but we found that could transiently restore sleep continuity in mice without causing any sedation. Okay, so to sum up this part of the study, we set out to look at what is the effect of peripheral nerve injury that causes neuropathic pain on sleep. And what we found is that peripheral nerve injury causes a spontaneous ectopic activation of injured nociceptors. that is then going to activate the pain pathways going through the parabrachial. And that then leads to a fragmentation of their non-REM sleep by brief arousals. And we propose that using this rate of brief arousals could be a good proxy measure for detecting spontaneous activity of nociceptors in preclinical models to develop new treatments and also to study better the mechanisms of spontaneous pain. We also believe that this is likely or has the potential of being true in humans and could also be a way to quantify the number of spontaneous pain attacks in patients, which is, again, as I said, something that is at the moment just we only rely on reports. Okay, now on the second part, which is a little bit shorter, second part of the talk, I would describe the other side of the equation. Some of the work we're doing to test how are sleep problems affecting pain sensitivity. And so I would start by saying that even before going into clinical settings for that, this question is highly relevant because there is a global, almost pandemic of people lacking sleep in a chronic manner. It's estimated that a good third of the population that is otherwise healthy is not sleeping enough. They are below the 8 expected 8 hours needed for restorative sleep. And that is something that is going worse every year with the advent of new technologies where people are able to carry on their activities before, instead of going to bed. And that can really strongly impact the amount of sleep they get each night. And this lack of sleep has many problematic side effects. It probably contributes to mental problems, obesity, but also pain. And I'm going to show you, we developed a model to test that, to try to mimic what patients are going through in mice. So the way to do that is, instead of relying on protocols that sleep-deprived animals, which tend to be pretty drastic and force them to move around, we developed a model where the mouse would be monitored in their home cage, and whenever they would show a sleep attempt, an attempt of going to sleep, we would give them a novel object, a toy, as you will, and we will just let the mouse engage in playing time. And as soon as the mouse would get bored, similar to a toddler, which doesn't last long, we would take the toy away and give a new one. So the trick of this protocol would be just to observe carefully and make sure that as soon as the mouse is bored, you remove the toy so that they don't get overwhelmed, and you put a new one. And this protocol works fine to keep mice awake for 6, 9, or 12 hours. So we did this, and at the end of the extended wakefulness period, we tested their pain sensitivity. And what we found is that you have, as alluded to in the introduction, you have a strong effect on pain sensitivity. You have a trend at 6 hours, and then 9 and 12 hours are causing a strong increase in heat pain sensitivity. So here you see that it's an increase in pain because it's a decrease in the threshold to remove the hindpaw from the source. And the von Frey withdrawal rates, that the pressure that is causing mild pain, is significantly increased in mice that are sleep deprived. We also tested capsaicin that I mentioned earlier, and you measured the time the animals is doing flinching and licking and tending to the hindpaw, and found that the mice had more pain responses after sleep deprivation. Perhaps as interesting, we found that non-painful stimuli are not affected by sleep loss. So if you look at cold, without normal cold in mice, or a brush just to test a touch, or even an acoustic startle when you measure when the mouse jumps with a different increasing, louder sound, we found that there's no increase in these responses. If anything, there's a decrease because the mice get sleepy. So that tells us that sleep loss specifically increases pain response. We did some pharmacology to try to tease out how that is happening. And the first drug we tried were NSAIDs and morphine. And strikingly, we found that none of those compounds were restoring normal pain sensitivity. Ibuprofen was not efficacious. Morphine had a slight effect on the hot plate and absolutely no effect on the mechanical pain hypersensitivity after sleep loss. Actually, it's even worse than that. We found that morphine lost its efficacy as an analgesic. The normal efficacy of morphine we could find in normal healthy mice is roughly 70% increase in their threshold. And it's only 20% when animals were sleep deprived. And that is something that has been found in humans as well, and could actually, as you can imagine, could be a major problem in clinical settings. If people are sleep deprived and require more morphine to improve their pain ratings, that will, it's a recipe for big problems. We also tested then the effect of drugs that restore alertness. And so we used both caffeine and modafinil, two drugs that can restore normal cognitive function when you're sleep deprived. And we found that these drugs, surprisingly, were capable of restoring almost normal heat pain sensitivity and totally restore mechanical pain sensitivity in animals, indicating that what's triggering the increased pain sensitivity in these mice, the sleep-deprived mice, is not an increase in the nociceptive pathways, but rather how the brain is managing the information. And here you can see that these drugs in naive animals and normal pain readouts don't have an effect on their own. So they only block the effect of sleep loss on pain sensitivity. But so that's one effect we found, that sleep loss increases pain by modulating how the brain perceives the pain stimulus. And we're focusing at the moment trying to understand the circuits involved in that. There's a lot of research focusing on the attention to pain or determining the saliency of the stimulus. And that might be what's causing the hyperalgesia. But the other, and that would be the last set of slides, the other question we asked is whether there would be some long-term effects of sleep deprivation. Could you be putting yourself at risk when you have not slept enough? And so to test this, we performed the sleep deprivation, 9 hours of sleep deprivation with the novel object. And at the end of this, we performed the plantar skin incision model I described as a model of postoperative pain and measured their pain over time. And what we found is that while this model, you can see in green, the well-rested animals, it's a transient pain hypersensitivity, but the animals return to normal values typically within a week or so, 2 weeks. Animals after sleep deprivation seem to have a longer abnormal pain hypersensitivity. And that has been actually found now in several studies. So the phenomenon has been, it's quite robust. If mice don't sleep enough, just a single night, that would be enough to cause effects on their pain recovery in this model. And so we're trying to understand the mechanism that could, be responsible for such a long effect. Because the thing I find amazing is we're talking about like a single acute sleep deprivation and an effect that you can see 2 weeks after. So what could be the substrate for such effect? And one potential candidate is the immune system. Sleep and the immune system are very linked. And so we reason that one possibility would be that when you're sleep deprived, you might affect your immune system. And then if you challenge it by an incision at that time, maybe that could have like a ricochet effect over time. So to have a sense of that, we are looking at the anatomy of the skin in these animals after at various times after incision. So here is a regular H&E staining looking at the epidermis and dermis of mice in well-rested animals, day 14, 21, or 42 after the incision, where you can see some immune cells and it gradually decreases to go back to normal. If you look at mice that had the acute sleep deprivation, you can appreciate that there are a lot more cells that we can observe at day 14 and day 21. And that is actually something we could quantify and find that indeed, in the dermis of those animals, you have a lot more immune cells at those late time points. We added the day 42 because we just realized that at day 21, that was so big that we just extended even further to get a good sense of when this is coming back. So you see that at the end, the immune response is going down, but it stays much higher than the normal situation in well-rested mice. We also found that by looking at these skin of animals, here I just blanked the epidermis, dermis part, but we could appreciate that while there was not too many immune cells in the muscle area over time, they seem to have too many of them in the sleep-deprived animals. And we quantified it and confirmed that indeed, incision itself doesn't cause a significant increase in immune cells in the muscle, but in mice that were sleep-deprived, we now find those immune cells in the muscle tissue. So that suggests that this could cause, sleep deprivation could cause a prolonged and spreading of the immune response that could have some downside effects on pain. So what we're doing now is trying to look at the nature of the immune cells that are staying too long after this sleep deprivation and incision. And to do that, we're using various markers. And here I show results with looking at macrophages. So in blue here, you have DAPI just for nuclei of cells. In green, you see a marker for all macrophages. But the interesting thing we can look at now is markers that will show M2 macrophages that tend to be anti-inflammatory and involved in the healing response. And the M1 macrophages that are the pro-inflammatory macrophages that are causing, they're strongly associated with pain sensitivity by releasing cytokines or prostaglandins. And now I'm going to show what happens in a mouse that was sleep deprived. So we confirm, yeah, you have more macrophages there. You have a little bit more of the M2s, the anti-inflammatory, but more strikingly, we have a huge amount of M1 macrophages that are still there 21 days after the incision, whereas they should be mostly gone. They should have left and let the M2 do their work. And so here I show just quadruple staining of the same markers in a normal mouse, when just like it should be mostly anti-inflammatory macrophages sticking around. But here in yellow, you see the cell that co-express the red and the green. Those are pro-inflammatory macrophages. And interestingly, it seems that they seem to be quite numerous in the dermis, the superficial part of the dermis, where a lot of nociceptors hang around. So that could definitely contribute to explaining the prolonged pain hypersensitivity. But it also shows to me the fact I find amazing that a single night of sleep deprivation before incision and 21 days later, you can see such drastic effects. So that, to me, it says that, yes, sleep loss could be a pretty important risk factor for developing abnormal pain sensitivity, and something that it would be worth keeping in mind before going for surgeries. And so the conclusion of this part is a little framework of all the possible effects of sleep loss on pain that can be quite diverse and dynamic. But what I showed here is that in the healthy animals, what we found is that sleep loss can increase pain sensitivity by, we think, mostly CNS changes in the limbic system area, by just, we believe, playing a lot on the saliency. The pain stimulus received by the brain is the same, but the response of the animal is amplified. The animal places more emphasis on it. There is also an effect of sleep loss on the reduced morphine efficacy that has been shown to be strongly due to a loss of excitability of the PAG, periagudical gray neurons, responsible for descending controls. And here, what I just showed you is that while in naive states, the immune system doesn't seem to cause an increase in pain sensitivity, sleep loss can place the immune system in a state of fragility, so that if you have a challenge at that time, then you have a shift toward pro-inflammatory responses, and then the whole response that is taking weeks might be amplified towards a pro-inflammatory profile that is associated with more pain. So that would be another way of how sleep loss impacts pain. And I added this one, so I can just, that was my last little slide just to highlight complicated things. But yeah, that's, I think, what we're trying to build from this simplified view of sleep and pain during the vicious cycle. That I think what we find is that, yes, there's a very strong interaction between those two systems, but they are much more specific, or based on what aspect of the pain are you looking and is altering sleep, and what aspect of the sleep problem goes to target the pain circuits. And so untangling that will help us, precisely identify how those systems, when the system interact, and how to mitigate the risk of adverse effects. And on that, I would, well, thank you for your attention for this. I hope I didn't speak too fast. And I would like to thank Clifford Wolf, where all this project started back in Harvard in the Children's Hospital. Chloe Alexandre, who is co-director of the lab where we started 5 years ago here at Johns Hopkins University. All the member of our lab here, as well as Michael Katerina and Alan Belsberg in the neurosurgery department, and Sang-Min Jian, who's been helping with the immune profiling, and our funding with the NIH, the Bluestein Pain Research Fund grants, and the Johns Hopkins Neurosurgery departments. And I'm happy to answer any question you might have.
Thank you for an excellent presentation. One of the questions is, are there studies using anti-CD specific antibodies to treat the elevation in pro-inflammatory markers?
Not at my knowledge yet. This is a pretty new field, at least for in regard to the effect of sleep loss on the problem. So not that I have seen at the moment, but that's definitely what we're thinking of doing at the moment. Is now that we're identifying the cell types that are, strongly increased after sleep loss and incision, we're going to see which ones we need to target to restore normal pain sensitivity.
Thank you. One other question was, is there any data in the humans, the surveys that you mentioned, were there any data in the humans regarding connection between pharmaceutical intervention and sleep in neuropathic pain?
Okay, that's a great question. And I wish the answer was yes, obviously, because that should be, but it's actually extremely hard to find the directive. I've been struggling to find and asked so many clinical fellows about trying to get a good sense of patients with specific treatments and what pain symptoms are well treated and what other symptoms occur. And there's no strong data showing that. What's been shown is you have an overall view about in patients which treatments are overall satisfactory and which ones are causing them to drop off. And so the main result would be for pain treatments, from what I've seen, especially for neuropathic pain, gabapentin and antidepressants can work. And in some patients, when they work, it's good. They don't work all the time. But you have a significant amount of patients who suffer from side effects from these drugs that are so bad that they prefer not to take the drug anymore. So they're stuck in a position where they prefer to try and deal with the pain rather than the treatment.
Excellent. I just want to remind everybody, please complete the program evaluation in the chat box if you'd like to receive credit. So the next question is, would giving a hypnotic agent affect pain control? Thoughts on that?
Yes. So again, great question. And that's definitely something we are interested in. I would start by saying, surprisingly, most of the hypnotic agents that we give to people are not triggering a very good quality sleep. So they actually, even the most prominent ones are causing, they put people to sleep, but then they stay in shallow sleep, not very good quality. So it's not, we don't think that it would necessarily work as well. We haven't fully tested this one yet. I mean, we have some experiments working on it, and I don't have firm conclusions about it. I would say that we used an indirect way. We tried that was a genetic model where you could trigger sleep by activating specific neurons in the brain. And we did that. We placed mice and forced them to sleep for several days in a row to have consolidated sleep. And that had some effect on the evoked pain sensitivity. And there's a recent paper that came out that was showing that putting mice to sleep could improve significantly their pain threshold after nerve injury. So I think that's definitely a possibility. I think that the concept is valid, but the risk is that the drug we currently have as hypnotics they're not great enough at the moment, I would say.
Thank you. If anyone has any other questions, you can place it in the chat box. So I don't see any questions at the moment. So I just want to say thank you for presenting, and hopefully you'll come back and present again when you have updates in your research.
It would be my pleasure. Thank you
Yes.
again for inviting
Thank you
me.
again for attending. Thank you.
Okay. Bye-bye.
Bye.